Okay, hi, welcome everyone. Dr. Saurabh Jindal here. Namaste. I'll talk to you about the FMGE questions, and I'm happy to say that the exam happened just yesterday, and we are in with your questions. Okay, so this is the Recall Dermatology. Dr. Saurabh Jindal. I've been with coaching institutes now for a long period of time. It's been 16, 17 years. So good for me to connect with all of you. Obviously, one disclaimer for this is obviously these are recall questions. These are not my questions. Whatever we could get from this early time. So it's been about just 24 hours and we are out with the video. So I'm happy to share that my backend team has worked a lot. So congratulations to the DBMCI backend team to give me these questions. Obviously, there's obviously going to be some possibility of errors. So I'll be open to you correcting me as and when you see some of them. Obviously, there'll be some mistakes, and but that's okay. At least I'll get the concepts in and I'll get the questions in. Also, for you to know that's all the questions, all the options we don't get. You know, sometimes from students we get 2 options or 3 options. So that again is something you have to accept, and you know you can guide me on that. Images obviously are not going to be the same, you know, because it's difficult to catch the exact image which came because most students don't even recollect that. So that's something that I want all of you to, that's a disclaimer for us. And then with this, I hope you got questions correctly. Let's discuss the questions in detail. Okay. So let's look at the first question. All of you ready? Come on, let's look at the recall questions for FMG just yesterday. Melanin is derived from, okay. Now melanin is obviously a pigment, okay. Melanin is a pigment that comes, let me just explain that to you, okay. Melanin is a pigment in the bottom of the epidermis. So this is the melanin now, in the bottom of the epidermis, right. Now this is the melanocyte, okay. We call this the melanocyte, let's call it short form wise MC, melanocyte, okay. Now this melanocyte tends to have these finger-like projections, and that's why we call them dendritic, okay. We call them dendritic cells, right. Now these dendritic cells are the reason why you transfer this melanin. It goes into the finger-like projections, and from here this finger-like projection enters your keratinocytes, okay, and the melanin now interestingly drops into the keratinocyte. So can you see now the melanin, okay, the melanin here, okay, 1 second please, okay, the melanin is inside the keratinocyte, okay. The pen is giving me a bit of trouble, so I'll explain that to you. Melanin is inside keratinocytes, right, and this is the melanin transfer happening. Now how do you make melanin, and why do you make that melanin? Melanin basically is something that you make from an amino acid called as tyrosine. So what happens when tyrosine gets converted to melanin with the action of enzyme tyrosinase, okay, with the action of enzyme tyrosinase, okay. This tyrosinase enzyme is an important enzyme to understand, okay, because a lot of melanin synthesis comes from there, and this tyrosinase enzyme is genetically controlled. Okay, means if you have a lot of tyrosinase, you will have a lot of melanin, so that's why you will have dark skin, right. So that'll be like a negroid person or an Indian person who's got a black father and a black mother will have a black child, yeah, and an American who's got fair skin will have a baby who's fair. This tyrosinase is also environmentally controlled with the amount of sun you get. So even in India, if I'm going to be outdoors more, I will make more melanin because I'll have more tyrosine activity, more melanin synthesis. So melanin synthesis is either genetically controlled or sun controlled. In fact, this tyrosinase is absent in people who have albinism. Okay, it is absent in somebody who's got albinism. And that's why in albinism what happens is you have tyrosinase, but you don't have melanin. So I'm just crossing the melanin out. Okay, so you have tyrosinase. Sorry, you don't have tyrosinase, so you don't have melanin, and that's why they don't have dark skin. They tend to have obviously white skin, and that is an albino or albinism concept that I want you to understand. So now you get this concept why we say that melanocytes typically make melanin from the amino acid tyrosine, and that is a very, very important amino acid for us to have in the skin. Did you get that correctly? I hope you got that correctly. Okay, so that's the first question. Not very difficult, simple question to pick up, and melanin synthesis is what we discussed on this particular image, right? Okay. Let's look at the second question which came. Okay. Only dimorphic fungus, which is also a subcutaneous mycosis. Only dimorphic fungus, which is also a subcutaneous. What is a subcutaneous mycosis? The word sub, okay, means below, right? The word sub means below, right? Okay, let's look at that now. The word sub means below, cutaneous means skin. Okay, so we say if this is the skin that I'm drawing, this is called the epidermis. Okay, this is called the dermis, and this is called the fat. So 3 layers of skin, right? Now if you have a fungus somewhere here, meaning a bit in the dermis, a bit in the fat, so this is called subcutaneous, meaning below the cutaneous architecture, right? Below the area. So these are also called as deep mycosis. See the word deep mycosis because it's deep. It's not superficial. It's deep mycosis. Now you have to know one thing, that sporotrichosis, which are the diseases which are included in the term deep mycosis. Okay, sporotrichosis comes in the category of deep mycosis. Okay, chromoblastomycosis, the second option, is also in the category of deep mycosis, and mycetoma, third one, is also in the category of deep mycosis, right? So that means the 3 mycoses, 1, 2, 3, all, but fourth, tinea, is not a deep mycosis. In fact, the tinea disease is in the epidermis. The tinea is a fungal infection in the epidermis. So that is discounted. We don't even want to consider that. So the only option you need to choose from is A, B, C. Are you with me till here? So you want to check between A, B and C, 3 subcutaneous mycosis for you to look at. That's what we narrow down to. Now let's look at sporotrichosis. Now sporotrichosis is a fungus which is there in the soil. So what happens is, look at this. This is a farmer or a gardener, let's assume. He's working with his hands. Now he gets a thorn prick. When he gets a thorn prick, there's a sporothrix in the soil, and that comes here. And then this sporothrix travels like this on the upper extremity, like this. Okay, or like this, right? So that is called sporotrichosis. Typically, the sporotrichosis fungus, okay, will create, interestingly, a nodule. Can you see the nodule? Yeah, and this nodule travels upwards like this, right? It travels along the lymphatic. So we say there's nodules along the lymphatics. Okay, the nodules are traveling along the lymphatics, and then these will burst to create a sinus. Okay, so there will be a sinus formation, mean pus coming out from those nodules. So see, look at the morphology of sporotrichosis. Typically, clinically, I'm talking about clinical first, so that you have other information also. Okay, so clinically you will have, clinical feature CF is you have nodules and sinuses along the lymphatics of the upper limb or the lower limb, typically coming in a farmer, and we are expecting that also to come in a gardener. So it can be called as rose gardener's disease also, rose gardener's disease, because they're picking up roses from the garden, and that's rose gardener's disease, sporotrichosis. Now this sporotrichosis is caused by the fungus, okay, which is sporothrix. It's caused by the fungus which is sporothrix, okay. Okay, so this sporothrix, okay, we call this sporothrix schenki. We call this sporothrix schenki. That's the organism we are talking about. Okay, now this sporothrix schenki is a dimorphic fungus. Okay, dimorphic. The word dimorphic, di means two, morphic means morphology. Okay, so there are two morphologies for this fungus. It's called dimorphic fungus. Dimorphic, are you getting this? Dimorphic fungus. Two morphologies means there's a yeast form plus a hyphae form. There's a yeast form plus a hyphae form. That's called two morphologies. So that's why it's called dimorphic. Okay, dimorphic fungus, and that is typically the sporotrichosis that we are trying to create for you here. And that the answer, if I go back then, is obviously the first one. It is sporotrichosis as the question, as the answer on this particular disease. Are you with me on this? So there's yeast form and a hyphal form also, okay, for this particular disease. In fact, the yeast and hyphal form actually, are, if you do a histopathology, then you will find a yeast form in the middle and a hyphal form like this. Okay, this is the hypha form. So this is a colony like that, a yeast in the middle and hyphae, and this is called as asteroid bodies. We call them asteroid bodies, okay, which is the histopathology, for this particular sporotrichosis disease process. Are you with me on this? Okay. Now what about the second option? I'll just discuss the second option also, which is chromoblastomycosis. Okay, what is the second option? Chromoblastomycosis. Chromo. Okay. Now in chromoblastomycosis, okay, no, before that, sorry, not that. First we'll discuss mycetoma. Okay. Now mycetoma typically is a fungal infection, again a deep mycosis, and mycetoma typically comes as like this. Can you see what I'm showing you? It basically comes as a swollen foot. Can you see the swelling of the foot? And can you see some sinus? Okay, can you see this arrow is pointing from a sinus, means some pus, and through this sinus something called as grains come out. So there are three features of mycetoma. Again, coming in a farmer after he's walking barefoot. So he gets a barefoot, he gets a thorn prick, and through the thorn prick he has this big swelling on the, see, it's not traveling around the lymphatics first of all. It's basically just on the foot, a local tumor on the foot, and then you'll have some sinuses and grains coming out from, this is called mycetoma. Now mycetoma fungus is not a dimorphic fungus. This is caused by Madurella mycetomatis. Okay, this is caused by Madurella mycetomatis. Madurella mycetomatis causes the fungal infection mycetoma. Also the disease is called as eumycetoma. EU. The eumycetoma word is EU mycetoma. This is a fungal mycetoma. There's also a bacterial cause of mycetoma, but at the moment we're looking at the fungal cause of mycetoma caused by Madurella mycetomatis. That's not a dimorphic fungus. That's not a dimorphic fungus. Do you get that? Okay. That second option, chromoblastomycosis, which was there, I will discuss that because there's a question which is going to come later on in the topic about chromoblastomycosis. That time I'll discuss it. At the moment I'm not discussing that particular topic at this area. Okay. Now this is, by the way, just to show you the grain. Can you see the grain? This black colored grain which comes out, these small hard grains. These grains are nothing but the colonies of the organisms. These grains are nothing but the colonies of the organisms. Colonies of the organisms which are basically coming out from those particular sinuses, and that's basically called eumycetoma fungal colony. Eumycetoma fungal colony. Got this clearly? Okay, so that's the second question that we had. Look at the third question. Okay, the third question was about a special smear called as Zhang smear. In the word Zhang, the word T is silent. Okay, we call it Zhang smear. Can you tell me the diagnosis and the answer on this, please? The Zhang smear is used for diagnosis of, now these cells, can you see one nucleus here, second nucleus, third nucleus, 4, 5, 6, maybe 7. So multiple nuclei are clumping together. Okay, so what is happening here, if I just draw that, okay, there is one cell like this that you can see here, and it has multiple nuclei inside. Okay, this is simply called multinucleate giant cell. Okay, we also call it MNG, multinucleate giant cell. Okay, multinucleate giant cell, and this MNG is a classical symptom. Okay, is a classical symptom of what? Listen to this. MNG is a classical symptom of, is used for the diagnosis of, is the question that we have. It's a question that we have, is used for diagnosis of, and I think there is one thing that one student told me. I think there's one thing here, all except, I think was what was mentioned. Just let me just write that. Okay, I think that is what was, though I may be wrong. Okay, now just listen to this. Okay, let me just explain this. At least you should know the topic. As I said, you might have some errors. That's possible. Okay, but let me just discuss that. The question is, Zank smear is used for the diagnosis of all except, okay? Now, Zank is used for herpes for sure. Herpes simplex virus type 1, herpes simplex virus type 2, both have Zank cell positivity. And the fourth option is VZV, varicella zoster virus. Now VZV is varicella zoster virus, that also gives Zank smear positivity. What does not give you is HIV. Again, as I said, some of the options may be incorrect. You might have some up and down. On this question, I was not very sure on what actually came. But anyway, you know the theory at least on what it was. So Zank smear is, how do you do? You break the blister. You should break the blister. Take the fluid coming out. Do a GIMSA stain. And you look for the cells, okay? If you have multiple nuclei, you have one of the herpes diseases. It is either herpes simplex virus 1, which typically causes herpes labialis, some blisters coming on the lip. HSV2 creates herpes genitalis, coming on the genitalia. VZV is varicella zoster virus, creates chickenpox, also creates herpes zosters. So the herpes, this varicella zoster virus creates two clinical diseases. One is varicella, one is herpes zoster. Okay, both have Zank smear positivity. Both have Zank smear positivity. Okay? So what does not create Zank smear positivity is HIV. HIV does not create Zank smear. HSV1 creates, I told you, herpes labialis. That does have Zank positivity. HSV2 creates herpes genitalis. Herpes genitalis. That also has Zank smear positivity. Okay? HIV doesn't create that particular. So answer on this would be HIV. Clear? Okay. Let's look at the fourth question. I'm more sure of this question because a lot of students communicated to me like that. An adult male with multiple sexual partners has a painless genital ulcer. What is the next investigation of choice? And an image like this is given. Now, whenever you have a painless ulcer, the first thing you should think of is primary syphilis, which means what? This is let's say the penis. Typically, the primary syphilis ulcer is quite hard and zero pain. Okay, so this painless ulcer, we also call it hard chancre. We also call it hard chancre. These are painless chancres, and in this they're all spirochetes, and you can stain this by a special stain called as dark field microscopy. Investigation of dark field microscopy. Now, what do you mean by dark field? As a question, as the image says, dark field. Can you see the background is dark and the spirochetes are not dark? Can you appreciate that? Can you appreciate that? The spirochetes are not dark and the background is dark. So that's a dark field microscopy that you have, and that's an investigation of choice for people who have primary chancre disease. Okay, we cannot do a blood test at this stage. And the reason you can't do a blood test is because the spirochetes and the treponemes are inside the ulcer only. Right? So they are there inside the ulcer. So if they are there in the ulcer, they are not gone into blood. So if they are not gone into blood, you can't do a blood test, right? So that's why you can't do a standard test called as VDRL. VDRL is a blood test. Okay? But that is, for that you have to have this organism going into the blood. That blood phase would be called secondary syphilis. This is primary syphilis, where it's only in the genitalia. If you don't treat it, then it would go into the blood. Then it would be called as secondary syphilis. Then you do a VDRL. Understand? But at this stage, you want to do a DGI, dark field examination, where the spirochetes are not dark and the background is dark. So answer is like that. Gram stain is usually done for another disease called as chancroid. I'll talk about it. Chancroid is a disease of genital ulcers. Look at chancroid now. Okay, let's look at chancroid. 1 second, please. Let's look at chancroid. Now, chancroid is a genital ulcer. Again, this is the penis area. Now, in this, the chancroid, the first difference is there's going to be multiple ulcers. Can you see what I'm drawing? And it's going to be very painful. And it will not be hard, it will be called as soft. Okay? And this ulcer, you will take a smear from the ulcer and do a gram stain. And when you do a gram stain, you get what is called as school of fish. I'll tell you what that means. So bacillus will come in a straight line as if it's a school of fish underwater. It's called a school of fish appearance for the disease of chancroid. Can you appreciate the school of fish? The base is coming in a straight line. That's a gram stain that you can appreciate, which is done. So it's not a dark field microscopy, right? It's a gram stain giving a school of fish appearance. Okay. HSV2 antibodies, not really, because HSV2 is, what did I say? Herpes genitalis. I'll show you that. HSV2 is herpes genitalis. Okay. Herpes genitalis is also on the penis. Interestingly, it will create blisters which are painful, and these blisters will create an ulcer which are again going to be painful. So it is again painful. The question said what? Painless. So these are blisters which are painful, and these blisters are typically grouped. We call them group blisters, and that's herpes genitalis that we can appreciate in people. Got this? So that's not the answer. Giemsa stain, the last one. Now Giemsa stain is also a stain that we use in STDs. Giemsa stain is used in a disease called as donovanosis. Okay, that's an STD. In donovanosis, the penis again has an ulcer. Now interestingly, this ulcer is extremely red. So I'm going to give it a bit of a red color. And the red is because it is very vascular and it bleeds. And it's painless. But the question has to say bleeding. There's no bleed mentioned. So if you do a Giemsa stain on this ulcer, you will get a lot of macrophages. And these macrophages will have organisms of donovanosis inside in a classical pattern called as closed safety pin. These organisms inside are called as Donovan bodies. I hope you got that now. Donovan bodies. Okay? Okay? Got it what I'm saying? So this is vascular. I'm just trying to give you some information about the other options also. Okay, so this gives you a holistic idea on what we are doing here, right? So that's the Donovan body, okay, inside Donovan. So that answer on this would be dark field microscopy. Clear? Okay. Next question. Okay, this again is a common question which is appearing in many exams now. A traumatic implantation in a forest worker followed by formation of a cauliflower-like verrucous growth. So again, images might not be the same. You can see this some kind of a cauliflower growth, and you can see some bodies here. These bodies are typically called copper penny bodies. We call them copper. Can you see copper colored bodies? Now these are the fungal spores which are there in the dermis. And can you see these are brown colored? But we have not given it some special color. It's automatically colored. It's automatically colored, and this basically was chromoblastomycosis. Okay, this was not asked. Okay, no problem. I got this as a feedback. Okay, but it's okay. Anyway, I'm discussing the topic. Don't worry. So it might not have been a question, but it's okay. So chromoblastomycosis is basically a copper penny body with a bit of cauliflower-like mass. So answer would not be sporotrichosis. It is chromoblastomycosis. Okay. Okay. See this question. Sixth, a patient comes with silvery micaceous scales. I am sure this was asked. Okay, I am sure this was asked. Okay, a patient comes with silvery micaceous scales and nail pitting. Patient comes with silvery micaceous scales and nail pitting. There is scaling on the elbows. Diagnosis is okay. Can you see some scaling on the elbows? Can you see some silvery scales? Right, and this is basically psoriasis. Okay, this is basically psoriasis. Can you see this psoriasis? Okay, and why is it not lichen planus? Now lichen planus usually would be purple. Okay, this would be purple. Okay, so LP is purple. This is not purple. This is definitely psoriasis. Silvery scale, simple question. Now eczema usually would be mentioned. They'll be mentioning of oozing. Okay, they'll be mentioning of oozing. Okay. Liquid coming out, that's not mentioned here. Pityriasis versicolor would usually be a bit of hypopigmentation. Pityriasis versicolor would be a bit of hypopigmentation. Okay, so this is basically hypopigmentation. This is definitely psoriasis, no doubt about it. No question on this particular question, right? Okay, look at this now. A 30-year-old truck driver with a history of genital ulcer comes to you. The image is as shown. What is the case below? What is the case below? Just confirm whether this was also asked. One of the students give me that feedback that this kind of a question, truck driver question, there's some hand and foot image which came. Okay, right? Can you appreciate that this came? I'll be glad to see your feedback on this. Okay, now this hand and foot lesion, a bit of a scaling lesion, would usually be secondary syphilis. Now truck drivers usually have more incidence of STDs. Yes, more incidence of STDs. That's because obviously they have more high risk behavior because they're traveling in a truck, they have a lot of sexual contact, they're out of the house for a long time, so they can do that. So they can get a palm and a sole lesion with a bit of scaling, so that's called secondary syphilis. Why not hand, foot, mouth? Hand, foot, mouth usually would be blisters. Usually it will come in children, and usually there'll be fever. Okay, so blisters, children, fever. Usually hand, foot, mouth. This is typically a scaly disease. Okay, coming on the hand and the foot, okay. This again, I think this was also asked, though again the image might be different to what was asked for you. A patient of acne comes to you, see the lesion given and identify. Now what students told me was there was a comedone image which was given, so I'm assuming they are right when they communicate to me like that. So the comedone is a blackhead. Okay, and one of the students told me that some lesions were given, you were asked to identify the lesion, whether it's a papule or a pustule or a comedone or a nodule. These are called as blackheads or whiteheads, technically called comedones, and that's a classical lesion of acne. Okay, a classical lesion of acne is a blackhead which is an obstruction of the tip, obstruction of that particular area, and this is basically the comedone that you get here, comedone that you get there, right? So that is the answer on this particular question. Okay, now see if this was also asked. Please confirm if this was also asked. A patient of some students told me there were 2 lichen-planus questions, so I'm going to put that up to you. This is one question which they told me was asked. I may be wrong, just correct me if that happens. A patient of lichen-planus comes to you. The pathology in chronic inflammation of the epidermis, chronic inflammation of the lower dermis, chronic inflammation in the dermoepidermal junction, okay, and chronic inflammation in the fat. Okay, so the interesting thing about lichen planus is a lot of inflammation. If I just draw this image, a lot of T cell inflammation happens here. Okay, this is the T cells. We know psoriasis, lichen planus is a T cell autoimmune disease. Okay, is a T cell autoimmune disease. Okay, and this is a T cell inflammation. T cell at the dermoepidermal junction. There are so many T cells there. We in fact call it band of lymphocytes. Okay, band of lymphocytes. Okay, band of lymphocytes at the dermoepidermal junction. So the answer should be the third one. Chronic inflammation in the DJ. Chronic inflammation in the DJ. Okay, and this inflammation will cause the damage of this particular junction. So there's going to be a lot of DJ damage in people who have lichen planus. So the pathology was asked, and I think the answer should then easily be chronic inflammation in the junction area. Okay. Okay. Now look at this now. This is again a question. This is the 10th one, not the 9th one. I think the numbering is 10th on this. Okay, so you can kind of look at that as a 10th question. Okay, 10th question. Now a patient with oral mucosal lesions comes to you. Okay, there's an oral mucosa lesion. The student whom I spoke to said that there was some skin lesion image, and I'm assuming it's kind of a purple image. That's what I'm assuming that is how it is. He also has skin lesions as shown the diagnosis is. It's a very classical purple skin image. Plus, if you have oral mucosa involvement, this is obviously oral lichen planus. Okay, so I think this is what the question would be. Psoriasis would usually be a bit of a scaling that you actually had. Okay, so this is oral mucosal lesions, comes to you, it has skin lesions as shown, and diagnosis is this. Okay, so I have recounted 10 questions, and whatever feedback I've got from you, from this, whoever was live, I think one question is not there. Okay, so I think what we now know is this question was not there. Okay, so I'm just crossing that out. It's okay, that happens because some student told me. It's okay, you got extra information. Okay, and this is not in my hand. Obviously, whatever students told me, I'm putting that. So it's okay, you got some information, but at least 9 questions were bang on to what was asked. So I think there's no confusion on that particular aspect, right? So with this, we got our 9 questions in. Okay, so I hope you got your dermatology, a simple dermatology, not very difficult to understand, not very difficult to pick up, right? And that is my solution, video solutions. And we are very early, just 24 hours since we completed the FMGE questions, right? And the exam got over. So we were out very quickly with what we wanted to do. Obviously, there's possibility of some errors here and there, but it's okay. You got overall snapshot of what we did. Okay, so I'm Dr. Saurabh Jindal signing off. Thank you very much for your time, and I hope you got many of your derma questions correctly. All right, thank you very much.